CAR T cells are probably the hottest topic in hematology these days. And this is really a fascinating therapeutic tool, rejuvenating the whole field of cellular therapy. Acute lymphoblastic leukemia has been the first approval for CAR T cells in young patients and children. And the oldest and longest follow-up about the use of CAR T cells we have is in patient with acute lymphoblastic leukemia. And the majority of the experience today is in patient with relapsed or refractory acute lymphoblastic leukemia. And actually now, after the initial very exciting experiences, we have now an accumulating body of evidence, several dozens of patients treated in different places with different CAR T cell constructs. But at the end of the day, there is really quite a common denominator where we have a high response rate, more than 80% of complete remission in most of these trials, including a high level of MRD negativity. And MRD negativity is proving to be a surrogate marker for survival. When it comes to leukemia-free survival in these heavily pre-treated patients, again, across trial, the results are around 40 to 50% leukemia-free survival at 1 year. And most importantly, we have a significant bunch of patients which are probably cured over the long term, because when we look to the shape of the curves, it's clearly a plateau after 2 years. So clearly, CAR T cells in acute lymphoblastic leukemia are here to stay. Obviously, we need to improve on the management of side effects, especially neurotoxicity and the cytokine release syndrome. Of course, we should not ignore the fact that up to 20% of these patients are going to relapse with a CD19 negative relapse. So a lot of work is needed to see how to salvage these patients. So in summary, I would say the use of CAR T cells directed against CD19 is currently strongly making it into the daily practice. Of course, we need to know and to learn how to position these cells. Is it consolidation? Is it bridge to allogeneic stem cell transplantation? Is it salvage after allogeneic stem cell transplantation? Should we combine CAR T cells as salvage followed by allogeneic stem cell transplantation for those patients who are eligible and have a donor? All of these are open questions, but definitely the CAR T cells in ALL are making a difference. And I believe the natural history of the disease is going to be changing soon, especially if these cells are going to move earlier in the course of the disease.